Hi, everyone. As she mentioned, my name is Katie Benchich. I'm a nurse practitioner at Flatiron Health. Previously, I did work at UC Health in the melanoma clinic, and I was a substitute investigator on 2 TIL trials. So today is just a brief overview of TIL therapy. Let's see. So first and foremost, why are we talking about TIL therapy? It's not an approved therapy. Currently, there's no FDA-approved tumor-infiltrating lymphocyte therapy for the treatment of cancer. However, there is a pending approval right now. TIL is a treatment that's been around. It's been being investigated since the 1980s and has consistently shown objective response rates between 30 to 50% in patients with metastatic melanoma, including those who have progressed on checkpoint inhibitors as well as targeted therapy. With these advances that we've seen in melanoma, we have seen improved overall survival. However, still approximately 50% of patients diagnosed with stage 4 melanoma will die from their disease within 5 years. So TIL therapy could fit an unmet need in this patient population. LN-144 is a TIL therapy that is currently pending approval at any time with the FDA. So what is TIL therapy? It is a form of immunotherapy that seeks to isolate and expand lymphocytes from the tumor environment. Presumably, these cells can target the cancer themselves. So you isolate them, expand them, and reinfuse them into the patient with the hopes of creating a cell-mediated response. So 2 studies I want to highlight are 2 of the larger and most recent studies. The first one is with LN-144. It's a phase 2 single-arm, open-label, multi-center trial with patients with stage 3C unresectable or stage 4 metastatic melanoma who have progressed on at least 1 line of PD-1 therapy, and if they have a BRAF mutation, have also progressed on BRAF and MEK inhibitors. Sorry, I cannot read the slides down there. My eyes aren't that good. So that study showed an objective response rate of 31.4%, median overall survival of 13.9 months, and 12 months overall survival of 54%. This data comes from pooled analysis of 2 different cohorts. So in that arm, all of the, that's what the asterisk is for, but all 153 of the patients did receive TIL therapy. The second trial mentioned is the only phase 3 trial with TIL therapy. And this again was for unresectable stage 3C or 4 metastatic melanoma. Patients were randomized 1-to-1 between receiving TIL therapy or ipilimumab. And that was dosed at the stage 4 dosing of 3 mg per kg every 3 weeks with a maximum of 4 doses. 84 patients were in each arm. About 90% of the patients had progressed on 1 line of PD-1 therapy. However, that could also be in the adjuvant setting. And then there were 9 patients that were treatment naive. So in this study, TIL had an objective response rate of 49% versus 21% in the ipilimumab arm, improved median overall survival of 25.8 months versus the 18.9 months, and median progression-free survival of 7.2 months versus 3 months. So they met their goal of doubling progression-free survival on this arm. If you look at the 2 different studies, what stands out to me is there's a pretty big difference in objective response rate. However, if you look at the patient population, it was vastly different between the 2 studies. On the LN-144 study, median number of prior treatments was 3 versus just the 1 line of treatment. They also had more visceral tumor involvement, liver and brain disease, higher LDH levels as well. So worse prognostic factors leading into it. So the TIL process, there's really 4 major points for the patient. The first starts with tissue procurement. So that's surgical removal of a portion of a tumor. Across all the studies, it ranges in how much tumor they actually need to get the TIL from. The LN-144 required a tumor aggregate of 1.5 centimeters, and the phase 3 study required 2 to 3 centimeters in size. The TIL are then separated from other cells in the tumor, multiplied into the billions in a lab, and then cryopreserved for patient use. Now, this process, once the lab receives the tissue, the total time period varies across studies, from 3 weeks on the low end to 3 months on the long end. The LN-144 reported around 22 days for their process. Next, the patient is admitted. They first receive lymphodepletion therapy. This is a non-myeloablative chemotherapy regimen consisting of cyclophosphamide as well as fludarabine. It's called non-myeloablative because it's less toxic than some of the traditional transplant treatments with lower doses of the chemotherapy and no radiation. And this is with the hope of helping with the TIL engraftment. The chemotherapy can help eliminate some of the T regulatory cells. Next, they receive their single TIL infusion, and that's followed by IL-2 bolus infusions. There's no set dose or regimen at this time, and again, since there's no approval, I'm just giving you a general overview of what's been done previously. But the IL-2 is vital for T cell survival, and it helps to further expand the cells. The 2 studies I talked about, they both use the same dose of IL-2, bolus dosing every 8 to 12 hours. The LN-144 study did a max of 6 doses. The phase 3 study, a max of 15 doses. However, looking at it, there were no patients that actually received all 15 in that regimen. And both studies did allow for early discontinuation due to side effects. Following that, the recovery from acute side effects, and then they're discharged to outpatient care. The majority of the side effects that were reported across the board in these studies were attributed to the non-myeloablative chemotherapy as well as the IL-2. Primarily, all patients in the TIL arm had grade 3 or 4 cytopenias, which is common with that chemotherapy regimen. So primarily thrombocytopenia, anemia, and some febrile neutropenia, and then the usual GI side effects. The IL-2 side effects were dose and regimen dependent. However, there were reports of capillary leak syndrome, fevers, rigors, hypotension, and hypoxia. The TIL infusion itself, it was not common, but there were 2 cases of anaphylactic reaction reported and a couple of cases of infusion reaction. They were not calling it cytokine release syndrome because they drew circulating cytokine levels, and they were not found to be elevated. So they were called just an infusion reaction. And then there were some autoimmune side effects, the risk much less than seen with checkpoint inhibitors and not the traditional ones that we would see a lot. Uveitis, hearing loss, vitiligo, and vasculitis were reported, although not in high levels. And most of the side effects with this regimen were seen within 2 weeks of the actual treatment. There weren't reported delayed side effects. Then they moved to outpatient management. This is really vital. Once they leave the hospital, this is not the end of the treatment. Pre and post TIL infusion, they need education and coordination. This treatment regimen requires multidisciplinary care, nursing, pharmacists, medical oncology, surgical oncology, cellular therapy between inpatient and outpatient teams, caregivers for the patients. Nurses are really vital in this role. I imagine there will likely be a nurse coordinator role position in a lot of centers similar to transplant to help manage these patients and help them through this process. So potential barriers, first and foremost, the patient has to be a surgical candidate. So they have to have enough tumor that's accessible, and they have to be able to withstand the surgical procedure. They need time to wait for that TIL expansion to occur. As I said, in the trials, it can range from 3 weeks to 3 months, depending on who's processing the tumor. Some patients don't have that time if they have rapidly progressing disease. In both trials, they did not allow for bridging therapy. However, in compassionate use, they have, which fits more in line with real-life care. That will likely happen. Cost, we don't know since it's not approved yet, but predicted upfront costs would be high. It involves surgery, inpatient, outpatient management, frequent follow-up. However, some argue that since this is a single therapy versus potentially 2 years of immunotherapy or targeted therapy, that it could turn out to be a cost-effective therapy. That's yet to be seen. And then patient-related factors, comorbidities, performance status, rate of progression of their disease, all are factors that will need to be weighed in making this decision. So the future, as I mentioned, currently pending approvals for the treatment of metastatic melanoma, but there's a lot of research going on in other solid tumors. Objective response rates have been demonstrated in non-small cell, cervical, head and neck, squamous cell, some mixed response seen with RCC, some GYN malignancies, and GI cancers. A lot of research looking into improving the regimens, improving the targets. Some studies are looking at specific targets of somatic mutations, but that would require whole genome sequencing or next-gen sequencing. Some are also targeting viruses like HPV. And then some looking at biomarkers to see if we can predict response so we can better select patients for this. So these are all ongoing areas of research. Also in the works is development of IL-2 analogs to help enhance the response to IL-2 without having those side effects associated with the high-dose bolus infusions. So not approved yet, but should be shortly in the future. And I think with ongoing research, it's likely to be a treatment we'll see not only for melanoma, but for other solid tumors as well. And we'll take a lot of coordination and cooperation throughout the healthcare team. And that's all I have.
Hi, thank you. That was very interesting. How many doses of the IL-2 did you say they received? Just one, or were there multiple?
So in the LN-144 study, they could receive up to 6 doses. They reported in that study a median of 6 doses. In the other trial, it was up to 15, but I think in that regimen, they mostly were, I think they reported a median of 4 or 5 infusions.
Okay. And then are they, they're in the hospital all that time, so that could be a really long time.
Yes, one of the studies I think reported a median of 17 days for hospital admission.
Okay, thank you.
You're welcome.
Any other questions?
And I think I did skip a part of the outpatient management too, initially monitoring frequent labs and transfusion support.
And you mentioned that patients have to wait a while for that TIL expansion to occur, and they have to be on bridge therapy. What is an example of that, of the bridge therapy that they're put on?
So they weren't allowed to be on bridge therapy on the trials, but just thinking in the real world, if you have a patient that has progressed on their previous line and they're waiting for treatment, potentially you could give a dose of chemotherapy, you could give BRAF/MEK inhibitors if they hadn't had that yet. Once people have progressed on frontline checkpoint inhibitors or targeted therapy, the response rates with reintroducing those agents is fairly low, but it might help slow that progression while they're waiting for their next treatment.
Any other questions? All righty. Thank you.
Thank you.